All right, the next topic that somebody wanted me to talk about this week was what do we do when a patient codes that has an Impella or a balloon pump? And I'm going to use this video to go over the Impella and what we do when a patient codes on an Impella. But really, the most important question is when do we actually code a patient that is on an Impella? And we don't want to necessarily allow an EKG strip or a arterial line waveform dictate when we are going to code these patients, because with some Impella devices, they can create adequate perfusion pressures and adequate flow rates in order to actually perfuse the body even during states of low pulsatility or fatal dysrhythmias. So we need to make sure we take that into account. We're not coding a patient unreasonably whenever this is happening. But when we do have a patient that is coding, when we don't have good perfusion pressures, like our MAP is low or our flow rates on the Impella are low, then we will actually start CPR. And what the instructions for use say on the Impella is to just reduce the P level. It doesn't state to go to P2, although a lot of centers will say in their algorithms to go to P2 in order to negate as much damage as possible to the myocardial tissue inside the ventricle, and to negate any damage to or as much damage as possible to the aortic valve, and to prevent as much suction issues, since we do have a ventricle that is going to be for more or less collapsed in on itself due to the decreased preload and due to exterior compressions that we are going to be doing to this patient during CPR.